The outline of this presentation would include to give a background, as I mentioned, about age-related disorders, to talk about variability, the relevance of blood pressure, and our ongoing efforts, and also the ones based on the current evidence, because we are not the only ones working on this, although we have some sort of unique data and unique hypotheses we've been able to test. So when we talk about age-related disorders, why we, if we want to picture, let's say, three different kind of our life, one in which we have an ideal course of aging, and one which we don't have risk factors, for example, diabetes or smoking or high cholesterol. So if we have this normal life course of aging, we're going to be a lower risk compared to this y-axis in the graphic to have conditions that will not only increase the risk of death, but also when they are non-fatal events, they affect the quality of life. Because for example, once somebody has a heart attack and survives, there's going to be a lot of changes that will result in conditions such as heart failure that will mean that it will cause a really huge impact, not only economic, but also to family. And that also matters when it comes to quality of life. So, in order to, if we prevent all these risk factors, we are at lower risk or we have better chances to have an ideal course of aging. But there's an average life course because not everyone is able to maintain a really 100% healthy lifestyle, but we have in the general population an average life course. Let's say that the problem comes when we have something that we denominate early vascular aging. That is someone who has, for example, that smokes, had very high glucose levels, cholesterol levels, blood pressure, that person is not only at a higher risk of developing conditions, but also that higher risk compared to other individuals will occur at any stage of their lifespan. So what we want to do is to address those. I mean, we want to stay in the healthy, or at least to have some risk factors, but that this does not go to once the disease develops. So this is kind of the concept when we look into age-related disorders. And a different picture, what these are, I have four here in which, for example, this is just the coronary arteries, how they look when they have lipids accumulation. That this is what causes myocardial infarction. We have here some examples of a stroke. That's just a blockage or hemorrhage of the cerebral artery that causes brain tissue death. Here's an example of a normal brain compared to someone with Alzheimer's disease, for example, in which when you compare both brains, you're going to be able to see that there's a difference in the brain tissue, and that is what we one of the pathological hallmarks of Alzheimer's disease. That here, this space here is the hippocampus. Well, not all that. The hippocampus is just over here, but I just want to show you the atrophy, the reduced volume, brain volume that associate with the disease. And the other one here is we have, this is a vision disease, which I'm going to talk later on, which it is glaucoma. And disease is progressive and is also an age-related disorder and is characterized by a total vision loss over time. So of course, we want to better understand risk factors that will increase the risk of developing these diseases, and that's why for example, we have epidemiology. We do population-based studies in order to identify what risk factors might predispose people to develop these conditions, and to what extent are these not relevant, but to what extent are they common? If we look into data from the global burden of disease, we're gonna be able to see that, for example, ischemic heart diseases or a stroke, compared to the total causes of death, these are the most common causes of death. And I would, unfortunately, let's say these cardiovascular diseases, they are preventable in the sense that by treating conventional risk factors such as smoking, diabetes, or hypertension, we can reduce the risk of developing these, the most common causes of death worldwide. And here we have, for example, Alzheimer's disease. This is just a picture of how common they are. And then you might say, okay, they're pretty common, but is there other perspective why we need to look and prevent these conditions, or why is it important? From a public health perspective, one thing that we can add to this is that the population is aging faster. For example, here we have three graphics in different years: 1966, 2017, and then 2066. What you can see in the y-axis is the age group of individuals, and what you can see is that in both males and female, the distribution of people is going towards getting an older population. And because all these conditions, ischemic heart disease, stroke, Alzheimer's disease, high blood pressure, they are all related to to age-related disorders. What we're going to have in a couple of decades, we already have it right now, but this number of people with these conditions will exponentially increase. And therefore, we need to look into preventive strategies. And that's why we need to identify what we call risk factors, because what we want to is, once we get into 30 years from now, no, 40 years from now, sorry, what we want is to have a population, older population compared to right now, as healthy as possible. And this is why we've been doing this work. And there are many risk factors that we can have a look at it. From our perspective, from our focus, we look into, for example, hypertension. And this is the one that I've been looking since I started getting involved into research. And hypertension relates to different conditions, and depending of your what age groups you are, and these will have a different kind of association. But long story short, we know that there's an association with hypertension, and which might interact with, for example, physiological, psychological factors, lifestyle, environmental factors, that they might, in the first stage, impact cognitive functioning, impact brain tissue, which most cases is asymptomatic, and might lead to major neurological disorders such as dementia or stroke. And actually, there is evidence in which was published in the Lancet communication about the main risk factors associated with dementia. And they identify hypertension. Let me just try to get it here. The letters are very small, but they identify 12 risk factors associated with later development of dementia. And of course, you're going to be able to see all the different factors. I'm not saying that hypertension is the only one. As you can see, there are many other factors, but hypertension is one of them. That's the one that I've been focusing for a long time, and we still don't understand why. So there are some, for example, in this systematic review published here, there are some theories about the direct impact of high blood pressure in the brain, that someone who has an uncontrollable pressure over time, that high blood pressure is creating some sort of impact on the brain tissue that will eventually lead to microvascular damage. It can also predispose to the accumulation of atherosclerotic plaques, or lipid plates in the cerebral arteries, that will condition the development of a stroke, or will also condition the development of dementia, which we attribute as vascular dementia. But we know that one of the hypotheses that there isn't a direct impact of hypertension on the brain tissue. And if we know that hypertension causes this, so that's what the evidence has been showing. Of course, researchers, physicians, they want to test, what about if I treat blood pressure, or if I have a better control of blood pressure, will that reduce the development of dementia? So far, this was a clinical trial, the SPRINT trial, which was designed to test the hypothesis of a better blood pressure control for cardiovascular events. But then they did some secondary analysis, and they collected information about dementia. It was not the reason why they did a clinical trial, but But as a secondary analysis, they showed the association of better, in this way, a better control in blood pressure in relation to dementia. So I'm not going to go through the whole graphical abstract they reported in the manuscript. I just want to show that here they showed, based on the hazard ratios, they showed that there is a benefit of about 17% in reducing the probability of having cardiovascular events in people who have a better control of their blood pressure. With this in mind, we can say, oh, well, if we treat blood pressure or hypertension, that's all we need. That's we don't need to look beyond this. And by just treating blood pressure, we're okay. We're going to prevent the development of dementia. But that's the tricky part. And now we're going to start getting into variability, because looking beyond hypertension or high blood pressure, there are many studies that they've been reporting that variability in blood pressure might be an independent risk factor associated with cognitive decline or dementia. So variability is essentially, in terms of blood pressure, like how much your blood pressure changes over years or how much it changes every day, because blood pressure is a dynamic feature and it changes. So what what they have been showing, we also have been showing, is that variability is giving us more information, more predictive information beyond blood pressure to study age-related disorders such as cognitive decline or Alzheimer's disease. And this study published in JAMA, what they show is we have in the x-axis we have different age groups, and in the y-axis, we have the probability of developing dementia. So essentially, the higher the hazard ratios, the higher the probability of developing dementia. What they did is to plot the risk associated with blood pressure level, which is the blue-gray dots and lines, versus the variability in blood pressure. And what you can observe is that as people get older, actually a lower blood pressure, there is a negative association between blood pressure and the probability of developing dementia. But then if you compare this to the yellow line, or orange, I see it as a yellow line, where you're gonna see is that as people get older, the association between blood pressure variability and the probability of developing dementia is higher. So I know that I told you before that there is evidence supporting hypertension in relation to dementia. That is true, but just when comparing to blood pressure variability, or it doesn't mean that every study will show you that hypertension relates to dementia. It's just that you have in mind that not only hypertension but also variability is being identified as a potential risk factor independent of the blood pressure in relation to dementia. But then I told you, now we know the relevance of what we need to look into age-related disorders. Not only they are very common, but also the population is getting older faster. But then on top of those conventional risk factors, now we're looking into variability in blood pressure. And then what is variability? So variability, by the statistical definition of variability, is that we have a set of data points. Let's say that we measure height in 100 participants, and then we try to plot the distribution of those heights of the 100 participants. We're going to have some sort of what we call the histogram that it looks like this. And based on what metric you would use, let's say in this case, we use a standard deviation. Variability refers to the data points that are around the mean. So, of course, we have a mean value, but around that mean value, we have data points that go to the right side of the distribution and the left side of the distribution. So, just depending on what index you use, it is just to define the dispersion of the data around the mean. Another way to have a look at this, and I try to give you an example that will also have a relevance to why we're talking about today about variability, is let's say that we measure temperature in two cities. So we have city A and city B. And then we measure the temperature in different months of the year. Probably if sorry if I switch some more times here. It's just to give you an example. But then we have two cities. If we calculate the mean or the average temperature during the whole year in both cities, this is just an example. We're going to see that the mean temperature in both cities is 74. You might say, well, I mean, both cities, they have the same temperature, so it really doesn't matter to which one I'm going to go to live or which one I'm going to go to visit. But actually, if you look into the data, those data points that you registered, that you collected, you're going to see that, for example, city A, there were temperatures of 105, and then in August there were temperatures of 54. So you know that the mean value is not enough for you because you need to know whether if it's hot or if it's cold. But then when you look into city B, where you're going to see is that city B, the temperature remain kind of steady, 75, 76, 72 the whole year. And although both have the same mean value, when you look and quantify the variability, that is the data points that are distributed around the mean, you're going to see that city A has a higher variability. And that's what we will expect because there's more distance between the data points compared to city B. And let's say we want to plot this into the graphic. This is a graphic representation for city A with a mean temperature 74 and the same thing for city B. If we want to plot data points for city A, it will be something like this. We have some data points here, another one here, another one here. And for the other extreme, we will also have temperatures of 105, 105, etc. If we do the same thing for city B, we're going to see the data points, they are kind of distributed closer to the mean. So now that you have a better perception of what variability is, in biological systems, it would matter not only that there's more variability, but it will matter what kind of environment that is. Because if you look into variability separately, you want to avoid or you would like to avoid regions in which it is way too hot or is too cold, and you would rather prefer an area that has a steady temperature all the year. So this kind of concept or view about variability in biological system is the thing that is lacking right now, because what we use is just a number to say that is yes, the variability is high, and that's all we report. But actually, with this example, if you want to, let's say you as a human being, as a biological system, you know that where you're gonna be, in which city A or B, will have a different effect in your function, in your heart rate, in your breathing, in your blood pressure, in your everything. So this really matters to the way that we're looking into variability. There are some studies that they documented the value of, for example, what we call visit-to-visit variability in cholesterol. These are just different metrics of cholesterol. So what they reported is that a higher visit-to-visit variability in cholesterol, the higher the risk of cardiovascular mortality. So what it means, if we want to extrapolate that variability in this clinical context, what it means is that imagine that for over 10 years, you go to the doctor, and every year you go, they take your blood, they draw your blood, and they measure your cholesterol. If over 10 years you have a higher visit-to-visit variability in your cholesterol levels, and then you have a higher cardiovascular risk, clinicians assume that higher visit-to-visit variability is making that person to have less controlled cholesterol levels. Because if you have a higher visit-to-visit variability, it essentially means that every time you go to the doctor, you have a peak in your cholesterol levels, and that will essentially increase the risk of cardiovascular events. So in this context, that means something different, just not looking into an absolute number of variability. So with this, I'm just trying to take you through not only the statistical definition of variability, but probably what it means to every different kind of scenario or system. And this is why it's enough to keep focusing on variability from statistical definition, because statistically speaking, it really I'm not going to say it really doesn't matter, but just the definition is just that you have a range in which your data points go to one side and the other side of the distribution, and that's it. But we're trying to show that probably for biological system, this might represent something else. So the relevance of variability in biological systems. I gave you the introduction of our variability. The first part was to talk to you about age-related disorders. So if we wanted to test that idea, and basically most of the time, well, any idea that you have, you need to have a measurement. In our case, we needed to have a tray with repeated measurements so we can analyze variability, and that was 24-hour blood pressure. But also you need to have, at least in our field, something that tells why is that relevant. Because what would be the idea if I showed that there is a high variability in patient A and patient B, if I'm not able to show that that high variability increases the risk of any given disease? So we need, at least in our field, we need to have most of the time, we need to give a reason of why we need to look into variability. So then we needed a disease to start with. And at least that this is how I started. I know that our research group has been doing this for a couple of years more, but we needed to look into a disease, and that was glaucoma. What we used was 24-hour blood pressure to study variability, because this 24-hour blood pressure assessment is a normal, when you go to the doctor, it's the same method. You have a cuff, a bracelet that inflates and takes your blood pressure. The only difference that you can see the little box here. Participants, or patients, they go home and they do their normal daily activities. And this device will be recording blood pressure every 15 minutes or 20 minutes. That depends on how you set it up. We did it every 15 minutes during daytime, and every 30 minutes during the nighttime. So of course, because we were getting repeated measurements, you're going to have a set of data points that will have a distribution and that we can analyze and look into, for example, variability. So this was our measurement. Now the disease. And I need to tell you the disease because for this context of glaucoma, the interpretation of variability had a different meaning. The one that I tell you in the city A and B about temperature, that it depends on whether it's too hot or too cold. So for this disease, looking into variability had a different perspective. So glaucoma is the first cause of irreversible blindness in the world, and the disease is characterized by progression and a irreversible progression of vision loss. And nowadays, the only clinical factor that we can treat to prevent the disease is to reduce the intraocular pressure, because essentially having a high intraocular pressure, it will exert a mechanical compression in the optic nerve, this yellow layer there. And that mechanical compression to the optic nerve with time will lead to progression of vision loss. But then the problem was that about 50% of our patients with glaucoma with a normal intraocular pressure, they still experience progression of the disease. So then researchers and scientists started looking into what they describe as vascular pathogenesis of glaucoma, because they say it has to be something outside the eye, probably. And that's why they come with the vascular hypothesis, which states that the ocular perfusion pressure, that is the amount of blood that reaches to the eye or goes to the eye, in patients with glaucoma is reduced. And there are two main factors that determines the blood flow and supply to the eye. That is the intraocular pressure, but then I told you that most patients have a normal IOP. And the second factor is the systemic blood pressure. This is the mean arterial pressure. So we have systemic blood pressure and we have the intraocular pressure. The intraocular pressure was always normal, so now they needed to focus in the systemic blood pressure, and they actually identify that hypotension, so having a very low blood pressure, increases the risk of developing glaucoma, probably because when the blood pressure goes down, the ocular perfusion pressure goes down as well. It causes an ocular blood flow dysfunction, which eventually will lead to ischemia, that is, interruption of blood supply to the optic nerve, leading to retinal ganglion cell death and irreversible vision loss. This was about hypotension defined as a blood pressure level. But then we needed to, when we started looking into this, we knew that beyond blood pressure level, there are other conditions that predispose probably to to episodes of low blood pressure, and that is variability. So we started looking into the research gaps back then, about 3 years ago, 4 years ago, and we found that it was not clear whether 24-hour blood pressure variability is associated with glaucoma. We didn't know, even if it was associated, what is the contribution, how much does it add to the disease. And the problem was also that most of the evidence was based on visit to visit blood pressure. And if you remember the graphic about 24-hour blood pressure, it would allow us to, over 24 hours, to identify potential episodes of low blood pressure or nocturnal hypotension that might relate to glaucoma. So with this research gap, we started looking into to test the hypothesis, and for this we use two kind of studies designs. So the first one had to do with the population-based study, which we have a general population. Let's say this is the Rio Grande Valley, and out of that we take a small representative proportion of individuals of the Rio Grande Valley, and we also did not only a population-based study, but also a case control study. That is, we match individuals with, without and with the disease in order to look into our hypothesis. For the general population-based study, we use the Maracaibo agent study, which is located in Maracaibo, Zulia, and Venezuela. And for the case and control study, I created a registry where I was doing my PhD of patients followed at the glaucoma clinic who had 24-hour blood pressure monitoring, and I created this registry of patients with 24-hour blood pressure, different kind of diagnosis, but we test with these two sets of data, we tested our hypothesis. So the first thing that we reported, that we published, was that indeed a high 24-hour blood pressure variability was associated with the probability of developing dementia. We can see here the odds ratios, that is statistical metrics that tells you how many folds increase certain a certain risk factor is associated with, in this case, glaucoma. Once we were able to publish this association about variability in glaucoma, and here we go again about that interpretation about variability, about the CDA and B, the temperature, hot weathers, cold weathers, because we knew that it was not only about reporting that there's a lot of variability. We knew that for glaucoma, I told you before, what matters are the episodes where blood pressure over 24 hours drastically drops. Because when that happens, that might condition the eye to episodes of impaired ocular perfusion pressure or impaired blood flow and supply. So we knew that by just looking into a standard deviation of or any of these indexes about variability, we didn't have enough information to really understand this hypothesis, because we hypothesized that. In this graphic here, you have individuals with normal eyes, that is the blue line, and then individuals with glaucoma, that's the red line. So not only do you see that the red lines, they have a higher variability or more variability, but you can also see that during the day, they experience drastic drops in blood pressure. So we needed to quantify that separately. And again, compared to city A and B, we needed to look into what was really cold and what was really hot, because that might represent two different things, because in reality, your body's response to those different scenarios in a different way. So what we actually did was to identify and separately quantify dips and blips or increases in blood pressure. So dips in blood pressure were these red dots. And if you see the graphics in those red dots, you will see that they precede a very drastic drop in blood pressure. The blips or increases in blood pressure were the blue dots that you can see in this graphic. So we quantify them separately. We wanted to test their association with, we're talking about glaucoma. And what we actually were able to report, we created 5 indexes. Here I am showing you 3 indexes for dips and then 3 indexes for increases or blips in blood pressure. Long story short, to avoid going through all the statistics, what we observe is that individuals with glaucoma, they experience more drastic drops in blood pressure. For example, forget about the clinical perspective, but if you compare those drastic drops in blood pressure in individuals with glaucoma, 60 just versus 66, you're going to see that those individuals with glaucoma, they have a lower blood pressure. They have not only they deeper more, but they deepen longer, and it was lower compared to individuals without glaucoma. Then we needed to, because that was cross-sectional study, that was an observational study, we needed to at least show some association with longitudinal data. And that's why we use the clinical cohort that I show you, the registry of patients with glaucoma. And in that one, we were able to show that drops in blood pressure, the more your blood pressure drops, the faster the disease will progress. That's the take-home message from this graphic. So we already knew that individuals with not only glaucoma was associated with more drops in blood pressure, but also those experiencing more variability, more drops in blood pressure, their disease progressed faster. This is just another graphic to support and compare variability in blood pressure versus level. So these graphics essentially show that, for example, graph panel A, the different colors represent different groups of blood pressure. Panel A is for blood pressure level. You can see that during follow-up years, and this is progression of the disease. It's dividing 3 categories of blood pressure, let's say very high, normal, and low blood pressure. They were similar. There was not a significant difference in the progression of the disease according to these 3 groups of blood pressure level. But we did observe a difference when we divided variability in blood pressure. So if we had a high, normal, or low variability, we were able to see that the disease progresses differently according to your level of variability. And the higher the level, the faster the disease progresses. And the same was for dips in blood pressure. Once we were able to show that there was an association, the second research gap was what is the contribution? Because in the clinical practice, when they have a patient, they look into age, probably some sex differences, risk factors such as diabetes, the intraocular pressure that I mentioned to you. So they want to know, on top of these conventional risk factors, what will be the clinical utility or the benefits of adding another risk factor to the whole set of assessment that they need to do to diagnose and treat the disease. So we needed to show the risk improvement based on blood pressure variability. And long story short here, because it's too better to understand the basic model what it is. But I just wanted to tell you that the inclusion of blood pressure variability and indexes of drops in blood pressure improve the prediction or the risk stratification of glaucoma between 4 and 7%. That is, another example would be that if I include this kind of information into the assessment of individuals with glaucoma, I'm going to have between 4 and 7% more chances to identify individuals with glaucoma, which I wouldn't be able to do so if I didn't have this. So it's just to show you that at least on top of the conventional factors, risk factors, variability and these indexes improve the risk prediction of these diseases. This was necessary to talk to you about glaucoma was necessary because with this, by looking into the physiopathology of the disease, by looking into variability to see what it really means here, then that's what we've been doing for, I think, since I came here, in which we've been extending beyond the ocular system. So looking into, for example, the brain. When we were doing that work on glaucoma, we knew we were not. I mean, we knew that there was an association probably between blood pressure variability and cognitive decline, hypertension and cognitive decline. But looking into 24-hour blood pressure variability, we were not that sure because there was not much evidence. But the hypothesis of that variability affects the eye because it impairs the perfusion pressure to the eye. We thought that this might be also the case for the brain because the brain is also susceptible to changes in blood pressure. So when we look into conditions such as Alzheimer's disease, we know that there is a conventional definition of Alzheimer's disease by hippocampal atrophy or accumulation of beta amyloid plaques in the brain that causes brain atrophy, cognitive impairment. We know this classical definition of Alzheimer's disease, but recently there's there's a hypothesis that Alzheimer's disease might have a, it's not recently, some years, in which there's a vascular component of the hypothesis. And among those vascular components, there's one that relates to the cerebral autoregulation. So as I mentioned to you, for the eye, it was important to look into the association variability because more variability and more drops in blood pressure affects the eye, the ocular perfusion pressure. In the brain, it might also happen the same because the brain needs a constant blood flow and supply. And this operates steady, very well, into a certain range of the blood pressure. So in the x-axis, we have the systemic blood pressure, and we have a range in which the brain, within that range, it will maintain a normal function, a normal blood flow. But once the blood pressure drops too much or increases too much, it's going to start making pathological changes in the brain that will lead to, for example, cerebral small vessel disease, or the hypothesis for Alzheimer's disease is that impairment in the autoregulation is leading to individuals to low perfusion, cerebral perfusion pressure, which is being reported related to Alzheimer's disease. So because the blood pressure is a determinant of this cerebral blood flow, we still want to kind of test the hypothesis that the association between 24-hour blood pressure variability and Alzheimer's disease might be related, and that might be explained because of this impairment in autoregulation. So here are two graphics in which let's imagine that the upper graphic is when the blood pressure operates in a normal range, like this one here. So the brain is just able to maintain a normal blood pressure because the blood pressure is just changing in a decent range. But if you compare this graphic to a person with a very high variability, you're going to observe that there is more likely that this person is experiencing episodes of blood pressure that are going below this operative range or above the operative range. And that might predispose to the development of dementia and Alzheimer's disease. So before we wanted to get into variability, we needed to show the benefits of looking into 24-hour blood pressure, and we started looking into conditions associated to Alzheimer's disease, such as cerebral small vessel disease. So compared to a healthy brain that we can see at the bottom, in the bottom part of the graphic, individuals with an accelerated brain aging, they have, for example, lacunes or white matter hyperintensities or microbleeds. And the accumulation of these lesions in the brain increases the risk of a stroke, dementia, and Alzheimer's disease. So by looking into this, it will allow us to have a better preventive strategies because the disease still hasn't developed, and also we help us understand physiopathology because each lesion has a different mechanism. So we show that by looking into compared to office blood pressure, by looking into 24-hour blood pressure, and specifically the nocturnal blood pressure, it was more information about the development, the presence of this cerebral small vessel disease. So up to here, we knew that, hey, we have a great opportunity to look into these markers of Alzheimer's disease and related disorders by using the 24-hour blood pressure monitoring. So once we published this, and since I came here, we've been trying to use the evidence that we know right now, which is it's very lacking in terms of 24-hour blood pressure. And we want to use the variability, the data we have available about variability in 24 hours in relation to Alzheimer's disease and related disorders. So I'm going to talk to you about our ongoing efforts from perspective of the data that we've been able to publish, that we been submitted recently, and the paper, for example, that Nay mentioned to you, that it was yesterday they told us that it was accepted for publication. So this is one part of the ongoing efforts, and the other one has to do with the future projects we want to conduct in order to test this hypothesis. So in that order, to start with, this is something that I've been working as well with Shanna. She's been helping me on this one as well, in which we want to show before the development of dementia, of Alzheimer's disease, there's documentation that there are certain areas of the brain that changes about 10 years ago, and that relates to future development of dementia. And these areas are described as MRI AD signatures. So it's basically the thickness of different areas of the brain, of the parietal, frontal, and the temporal lobe. And what we've been able to it's not replicate because there's no studies. We are the first one showing an association between 24-hour blood pressure variability and different AD signatures, for example, in the superior frontal lobe, medial frontal lobe, middle frontal lobe, the medial temporal lobe, hippocampal volume, and AD signatures. So what this estimates tells us is that a higher 24-hour blood pressure variability is associated with thinner areas in the brain, different AD signatures, including the ones I just showed you in the red letters. And these areas of the brain, thinning of these areas of the brain, are associated with the development of disease. And one of those is the one that we right now, which is hippocampal volume. So this is a work in progress that we now we are in the phase of this. We have the main results, as you can see here, and we are describing the results and generating the manuscript. This is part of the of one that we submitted recently, in which we are looking into the association of blood pressure variability and the cognitive functioning. So in these graphics here, probably you cannot see it very well, but we have in the x-axis we have 24-hour blood pressure variability, and the y-axis we have mini-mental state examination. This is another type of cognitive assessment to assess memory. And what you can see, or probably you cannot see very well, is that a higher variability relates to a lower cognitive functioning. It probably should be something like this. You cannot see it, but we know that there's a statistical significance. And what we did with the blue and the red dots with the graphic, the division of the graphic, is because we wanted to show that depending on whether the person have hypertension or not, this association is different. And we were able to show that the blue lines are individuals with normal blood pressure. And among individuals with normal blood pressure, we observe an association between variability and lower cognitive scores. And this scores a hypothesis that the association between variability and, in this case, dementia-related disorders or cognitive functioning is independent of the blood pressure level. Then we needed to show we now have cognitive scores. Now we needed to, this is also part of that manuscript we submitted, to show the association with dementia prevalence. So when I submitted this work, I did it 2 months ago. We didn't get into the journal, we did a resubmission, but I'm telling you all this because when I did the first submission about 3 months ago, we didn't have any report, didn't have any evidence showing the association between 24-hour blood pressure variability and dementia. And it's not like we were just trying to look into hypotheses just because we've been following our story, but also there is a lot of decades of evidence showing a potential role of blood pressure variability, The problem is that it was not based on 24-hour blood pressure monitoring. So we really had a lot of support from all the story about that I told you about glaucoma, plus the evidence about long visit to visit variability. So here, when I submitted 3 months ago, we thought we were the first. But there was a publication also about 3 months ago that the reviewers commented. But actually, that is in a clinical trial in standard group that they show an association with blood pressure variability and dementia, the development of dementia. Still, we're the first one showing this association in the general population. So this is just to show you that 24-hour blood pressure variability and nighttime variability, a higher variability in these periods of the day was associated with a higher probability of having dementia. And other metrics of blood pressure level, they were not. This is and these are results. This is the graphical abstract of the paper that I mentioned that we just got accepted. So what we showed here is that we were able to have, and this was a work that I did in collaboration with Dr. Bacheva here at UTRUV, the Department of Mathematics, in which we have um, follow-up data of the 24-hour blood pressure and also cognitive assessments. So this certainly was not documented before. And what we were able to show is that in the x-axis you have the follow-up time from 0 to 9 years, and then in the y-axis in panel D you have the blood pressure level. You will not see a trend in the follow-up in the blood pressure level, and this is in individuals who have a progression of cognitive decline. As we can see in panel A, this is the mini-mental score, and what you can see is that over follow-up, they have a cognitive decline that was significant. But when we look into blood pressure variability, we observe that the higher variability over follow-up in this group of individuals was associated with cognitive decline, and we are waiting for the manuscript to be published, but it's already in press. So now that we've been reporting all this, we need to look into the association of the incident dementia, and this is work we've been doing. But then there are a couple of questions that we still need to answer. For example, doesn't matter which index we use, because, for example, we published that when we look into blood pressure variability and cardiovascular risk, it mattered whether we were looking into absolute changes among consecutive blood pressure measurements, or depending on the index, whether we're looking into hypertensive peaks. So this is also something that we need to elaborate better, which we know that for Alzheimer's disease or dementia and related disorders, the one that would matter the most, it would be consecutive changes among blood pressure readings. The other question is that we'll be showing only continuous or linear associations. That is, the higher the variability, the lower the cognitive scores, or the higher the prevalence of dementia. But we are still not able to tell what is a high blood pressure variability. And the same goes for cardiovascular diseases. They've been since I think the 80s. Italian investigators reported that we still don't know a threshold to define what is a high variability. So this is something that we still need to look at it. And I know that depending on the cardiovascular outcome, it will be different. We reported that probably for cardiovascular events, if your blood pressure changes about 12 millimeters of mercury, that will be considered a high risk, but probably depending on the outcome will be different. Another work that we've been doing as well with Antonio Garcia, he's from the Department of Human Genetics at UTRUB, is to look into that 24-hour blood pressure data and try to get signals of that information and create clusters of blood pressure. Because probably it's not only about looking into nocturnal blood pressure drop, but as a circadian rhythm, there might be different patterns of blood pressure, and these patterns might be also different depending on what disease we are looking into it. So this is something also an ongoing work that we've been doing. And part of the RCMAR project, which I'm going to discuss tomorrow with Dr. Gladys, Dr. Mahanis, and Dr. Aaron Manosov, based on recommendations, comments, suggestions that I got. But the RCMAR project essentially looks into the impacts of social determinants of health, vascular dysregulations, and brain markers of Alzheimer's disease. So we want to test the feasibility of this project. We want to test our to novel hypotheses about variability and superior to conventional metrics in blood pressure in relation to ADRD in Hispanics, and also to test the influence on social determinants. And you might explain why I suddenly I'm talking about social determinants of health. It's just because, by the way, the lattice and modify the hypothesis based on other recommendations would be receiving, in which we know that in the environment, remember CD A and B with different temperatures, our body reacts differently if we're in a hot or in a weather temperature. And the same goes that our system, our body reacts differently depending on which neighborhood we are, depending of which environmental stimulus we do have. So there is an inherent ability for us to react to adverse conditions or favorable conditions, but we do have a response to it. So by looking into the social determinants of health and that there is an association with ADRD, we want to understand that how much of this association with Alzheimer's disease and related disorders it's explained by vascular changes. And those vascular changes have to do with 24-hour blood pressure variability or vascular dysregulations. This is just a summary of what is what the project is going to be. Again, it's just to test the feasibility of conducting that kind of assessment here in the Rio Grande Valley, and this is how the protocol will look like. That which potentially we will include also this part of the South Texas Alzheimer's. So in conclusion, beyond the level, variability seems to be an independent risk factor for age-related neurological disorders. For Alzheimer's disease and related disorders, variability might be a novel biomarker associated with the development and progression of different conditions. And actually, there is even NIH grams, but that's a different. Uh, uh, it's not a different call, but because they focus on cardiovascular events, but there are calls looking into circadian patterns in the cardiovascular system that they might relate to outcomes where intestinal Alzheimer's disease and related disorders, but having those kind of phenotypes, specific signals, specific patterns in blood pressure or the vascular system over 24 hours might be a potential and modifiable risk factor. We don't know. That's where we are heading towards. You might say, I mean, to what extent is important what we're doing here? Well, these just are a few publications that they've been recently published this year, some of them just last year, but there is one here in JAMA Neurology, which was published 2 weeks ago, and they report 24-hour sleep activity, also, for example, walking, and they associate that with accumulations of beta amyloid plaques. So there has been also a really growing interest to understand 24-hour blood per 24-hour patterns in functioning circadian rhythm, and also by 24-hour blood pressure variability. You have one paper here, another one here, but this is what I meant. This blood pressure variability is not 24 hours; it's visit to visit. But it's just to show you that there is actually a growing interest to look into this, and we are fortunate to have the data to start testing this hypothesis. These are some very few current gaps that I believe there are, and from each one you can disentangle older 10 questions or 5 questions. I don't know how many, but these are the ones that we know that it's a priority. We need to test this in order for us to continue advancing. And I think it will have to do with uh, auto-regulation, or at least the capability of the brain to adapt to drastic changes in the vascular system. So we need to get traits of our variability in biological system. We intend to not only get blood pressure, but heart rate, temperature, breathing as well, because that might explain the association between variability and disease, and will tell us that direction. And what I meant with that direction, remember again, just the data points, although we have the same mean value, is not the same thing, because again, hot and cold weather, and that in biological system means something else that we want to better understand. For us, that would be to have vascular dysregulations on top of conventional risk factors that will help us to understand and have a better risk stratification of Alzheimer's disease and related disorders. This is my acknowledgement. That's all I have to share, and thank you very much for your attention.
Well, nice presentation, Jesus. This is great, really um, very illuminating for our field. And I think that, yeah, there is a lot to be done here. I would like to open the floor to our guests that we have 30 guests here today, which is outstanding. So thank you, Neira. You did a very nice job
Yeah.
uh, distributing all the information. And yeah, definitely we had a very nice group here today. If anybody has a question or any questions here.
And I think it will be nice also if somebody, when they pose a question or comment, introduce themselves, where they are and what they do.
I would like to start by myself here with this. Jesus, okay, the circadian rhythm is very important here. And now we also know some genes that are related to the circadian rhythm. That's very important, especially when you mention the variability across different places in the world and how people get customized to the different places. So how do you envision that, for example, people that are moving or a lot or that need to travel a lot from to different time zones or different heights, because I guess the height also makes a lot of difference here. How do you envision that, or how do you think this may be affecting also the circulatory system and those variabilities in the blood pressure?
Yeah, that's a good question and a trick one. And actually, I've been asked uh, when I talk about this, like, what is or is there any difference in blood pressure variability across different regions? And I have said, not aware of any study because so far I can probably tell that the reason of knowing if there are differences across regions is that blood pressure variability is being looked to cardiovascular risk. Probably for then it hasn't been relevant, but then I know, as you mentioned, that it will be relevant across different regions. It would be not the same having a blood pressure variability problem in the south of South America compared even to Venezuela, because we have data from an Uruguayan cohort, and at least we can hypothesize that it might be different. It will be also be the different for North America, for Europe. That has not been tested, or I'm not aware of. 24-hour blood pressure variability. I'm talking about that one. We do have the data to test that. I probably will test it for just for us, so if we know what is the answer, and then I would have to build up a really good argument to convince the people of the other consortiums, because that's also part of their data, to why it would be relevant to look into variability in different regions. But I believe it would be different, and also, as you mentioned, what is going to happen with people who travel a lot, or people with different heights. I mean, living in different heights, and that's what it meant with the capability of our biological system to adapt to it. So these individuals will eventually have, I'm going to call changes in their vascular functioning. If you are in a really hard place, then you have normal conventional just to compensate for the oxygen deprivation, but you will be able to adapt. So probably we will, because we cannot control for all these changes, but what we need to do is to test the ability of adapting and having a normal functioning after someone is exposed to a new environment. And that capability of adapting is what I believe it will be impaired in individuals with Alzheimer's disease. We'll need to test that one, and we'll need to figure out how we can test that one. But that's what I believe. That everyone will have a change, but they will be able to adapt. So the thing would be to identify those who cannot adapt.
Yeah, I think this is important, especially when people have to, for example, traveling. We know that it's a high risk for elderly people to move or to travel to high places, especially when their circulatory system or the oxygenation is not the best. I've seen so many cases of people going to the mountain and getting a cardiovascular event, going to the mountain. Yeah, that's important. So definitely if this happens, okay, what else can happen also to the brain? It's not the most popular, but okay, this is something that we have to also
It
consider.
does.
Yeah. Yeah, this is really interesting. The background of genetic variation. There may
And
be
the genetics,
yeah,
that's
yeah, yeah.
the
No,
other
the
part.
genetic
Yes.
variation. There may be
Yeah.
some alleles or people having more resistance to other than others for this, or getting better customization. I don't know, maybe.
Yeah, the genetics, that'll be at a certain point. Yeah, I don't see that in many going probably in the next 5 years, but we will need to include the genetics part. And
We will. We
the
will.
main, the main problem will be right now is that they use standard deviation as an index of variability, and as I explained to you guys, is by looking at an absolute number that is not really telling us something. So we will need to generate reliable metrics of blood pressure, of vascular dysregulations that we can then relate to genetics with the most accuracy as possible. Because now we're just using office blood pressure, and that for me is really it really doesn't tell us the whole thing. But yeah, that should be within the next 5 years. We'll have to at least to start collecting blood samples. Or yes.
Great. Okay, Gladys also has
Yeah, thank you, Ney. Thank you, Jesus. That was a very interesting. And we've talked a lot about different issues, but the question that Ney posed made me think that really we need to approach this as a gene-environment interaction, and in the sense that, if you think about it, like personality has something to do with reactivity, cardiovascular reactivity, and and perhaps Mario might comment on that, and the level of stress as well. And Jesus, you mentioned like during the day things change, like even when you are hungry, when you are tired, and all that, that might influence our response to just standing, for example, as we have learned with COVID, for example, that hypotension, orthostatic hypotension, also, is greater among people that suffer stress, not only having high blood pressure, but also having episodes of low blood pressure. So is there any evidence or studies done with personality and blood pressure variability?
They are the ones I'm aware of have to do with long-term blood pressure variability, but the one about 24-hour blood pressure I'm not aware of. Probably they are. I mean, when I look into the evidence, because remember we discussed the other time about doing the neuropsychiatric inventory, that will give us some metrics of anxiety, food disorders. It's not as personality as you just commented, but it will give us some information. When I did that search in 5 months ago, probably there was not that is in relation to 24-hour blood pressure. I believe that would be a topic that we will need, and probably or Mario or someone to collaborate with, because yes, we have that information, and I believe it would be a strong as I'm not gonna say a strong association, but there there must be an association because our vascular system responds to our emotions. So heart rate is the first thing that changes if we are scared, if we see something. If I open the door suddenly someone was entering at the same time, so there's a rapid response. It's a normal response. So we have this information, and it'll be a matter of building up a collaboration so we can pursue that part.
And the other thing is that the new blood pressure monitors, ambulatory blood pressure monitors, have accelerometers. So you might know how much variability it's actually related to being seated for too long, like most of us at work, or how much it's related to standing up. And I guess the more intellectual in this, I mean, in the US, it's not the same in other countries, but the more intellectual our job is, it seems like the more seated we are. And on the other hand, individuals working, you know, in jobs like behind a counter, for example, one of these fast food, you know, they are standing all day. So I'm wondering, what are the consequences of standing or too long or being seated too long in blood pressure variability, besides the obvious that if you stand and sit, this is going to have an impact on blood pressure variability.
Yes. And this is something that you mentioned as well. It was mentioned by in Washington by Melissa Guerra as well. So fortunately, with this new 24-hour blood pressure device, we'll be able to test that hypothesis. I didn't see it before. I didn't think about it. But then once you do, of course, as you have done right now, we will be able to test the hypothesis. And for orthostatic hypotension, we know that the inconveniences of, for example, having probably a job that you are the whole day standing, but that affects your venous circulatory system, blah blah. So, but we can have a physiological association with it. So, that'll be part of the RCMAR, but again, because I didn't see it before, I didn't write down that hypothesis. But in this new update, those will be one of the hypotheses that
and what about
we
consumption of salt? You know, I notice in the valley, I see that there is consumption of salty snacks, you know, quite often along the day. I don't know, that might be a biased observation. But I'm wondering about the high consumption of salt, how this, like in different times during the day, how this might impact the blood pressure variability.
That is also a possibility, and we know that in those extremes of consumption of salt, individuals, it will also be a higher risk of developing cardiovascular events. So I think with that premise, once we evaluate participants, representatives of the area, we should get some metrics of salt consumption. Sure, we can try to figure it out based on the diary. We can ask the participants to annotate at what time they eat, so we can correlate that with heart rate, for example, and see if there are changes minutes after they stop eating, they finish eating. But to really test a hypothesis, I think we need to look into urine then and get that. Yes, that urinary excretion of sodium.
Maybe there is already, a nutritionist or a dietitian that may have already look at the consumption of salt during the day.
Consumption. That is true. So we should be able to capture that information, and in the end, if we're able to get some at least clues about salt consumption, it's not perfect, but it's a questionnaire. We can then argue with that one to write a photograph or something to test it. Yes, Mark.
Thank you.
Can I make a comment? Hi. Thank you for doing this. This is the programa from the School of Medicine. May I make a comment?
Yeah,
Oh,
sure.
please. Thank you, Sarah, for
Hi.
being here and to.
Nice to see you all. I mean, I came a little bit later, but I'd like to make a comment. This is really good to have this done. I haven't had the pleasure of meeting you in some of you, Dr. Maestro. I think I met you, Dr. Maestro, in person. I think. But anyway, my comment is about hearing you about hypertension, and then the different implications in nutrition and our lifestyle. I just want to add that is very important. Maybe you already know about this. In our oral microbiome, to not to scratch or brush our tongue, because there is many different microbes, bacteria specifically, which would produce the nitric oxide, which is very much needed, not to lead to hypertension. So that's just, I thought of adding that comment there, since we're talking about hypertension and the need for people and individuals to understand what type of lifestyle. And it's something very easy, right, to make a habit of. And it would help, maybe not much, but it is important. It might affect.
So, Serena, say that again. So you are saying we should not, or we should?
No, because if you brush your tongue, then you are affecting the oral microbiome big time. You should brush your teeth, but not your tongue.
All right.
Now I have to tell that to my kids.
Yes.
and that so that
Thank you.
the alterations in the flora affects the bacteria to produce nitric oxide.
Yes, correct.
I didn't know. It may, I mean, if it affects the NO production, yes, eventually should also affect it. Oh, I didn't know.
So no, but that's a very interesting point, because the microbiome is not static, changes.
Correct.
I don't know how much during the day of that, if that will be relevant. I mean, I guess it's associated with what we eat and when we eat.
Oh, yes, for sure. For sure. You know,
Mhm.
it is all correlated, with our nutrition and the such. It's just that we don't want to mess around with our own natural way of getting that nitric oxide production, right, inside our own body. So if we can help our body, then by all means, right? So, but it's something that probably, depending on the culture, I don't know, we're told like, yeah, have hygiene in your mouth and make sure that you brush your tongue and all this. Well, it's not really that beneficial to brush the tongue.
Mm.
So, yeah. But don't forget about the teeth. Now that for sure, the teeth.
Yes. And I read about it.
Well, that was good to know. I'm a dentist, and I have always told my daughters and everyone to brush their tongue. And actually, I haven't seen. I hope I'm gonna look for an article, something like that about.
Oh, okay. I can send you if you like, but
Yeah. Thank you. Yeah, I'm Noe Garza. That Garza.
Yes, I see that your name here. Yeah.
Okay. So yes, please send it to me, and I'll check that.
Sure, for sure. Thank you. Yeah.
Welcome.
Thank you.
No. Thanks for your comment.
Hello. Drumhill, thank you for being here. Please.
Hi, so wonderful to be here. Thank you, Jesus, for inviting me. It's always a wonderful opportunity to hear you talk. Always a learning experience. And I work with Jesus back in Belgium for a summer internship. Then I applied widely. He is the best teacher, I must say. And now right now I'm a postdoctoral research fellow at Harvard Medical School. I'm also studying hypertension, blood pressure variability, diet. Dr. Maestre, which also mentioned sodium. So it was really, really, it got my mind thinking about like maybe absolute sodium consumption, because right now in the GoFresh trial, it's a trial to see if DASH diet, low sodium diet, is able to reduce blood pressure in people who identify as Black or African American. So that would be something which would be interesting to maybe see. And thank you so much for the presentation as well. I would also intrigued by the social determinants of health. That topic is really interesting in how that could influence blood pressure variability in Hispanic population.
Yeah. Thank you for your comment, Truman. It has always been a pleasure working with you, and thank you for coming by. But I will ask you later on about the clinical trial and what you guys are doing with it, because just when they're wondering if I'm going to measure 24-hour blood pressure in that specific clinical trial, and about the social determinants of health, it is, I mean, which again I have to admit I didn't see it before, but our body reacts to the environment. So this will allow us at least. Well, now I am reformulating the hypothesis, because now we have the part of the social determinants of health associated with Alzheimer's disease and related disorders. And what I want to test right now is how much of that association, that's the relationship between the two, is probably because of impairments or vascular dysregulations. Before it was the other way around, but now just trying to make it more sense about this. But even just looking into social determinants of health and 24-hour blood pressure, variability, or any index of night-to-day ratio and the functional lipid, we certainly don't know about that. But for example, one example that Dr. Gladys mentioned about people who stand in jobs for they stand the whole day. But what about people who have sleep disturbances or disorders because for neighborhood environment, or in those big cities, transport? I mean, the noise. I mean, all of that can certainly affect, and it will be the ability to adapt to it that will probably determine that association. So, yeah, the social determinants of health will be something. Are you guys collecting that information?
Yes, we are. In fact, recently we had a paper on social determinants of health and how they are affecting the blood pressure. So we have three kinds of blood pressure measurements. One is the office blood pressure, the BPM. And in another study, the ERIC study, we have the home blood pressure monitored day and night as well. So these are kind of two different studies. But yes, right now for the GoFresh study, where we're trying to see the sodium consumption, we have the social determinants of health information as well.
Oh, that would be great then to talk about. Okay, great.
Yeah.
Thank you.
Also, thank you, Dr. Maestre. Also, I know this is the first time we're really meeting, but it's been, he just always tells me how supportive and wonderful the environment is. So thank you for that as well.
Thank you. He also told me so many good things about you. So welcome to the family.
Thank you so much.
I just want to quickly comment at Dr. Garza. It's I put it in the comments there.
Oh, there you go.
Yes, I already said thank you. Thank you very much.
You're welcome.
Okay. Thank you. Yeah, if it affects and it's your outside, yes. Now I get it. Okay.
Hector has a hand raised.
Yeah, can you hear me?
Yeah, please.
Yeah, I just wanted to add something else. And those for you that don't know me, I'm Hector. I'm working on the clinical core here with Dr. Maestre and several other people. Just wanted to touch real fast on what she said about sitting down for prolonged periods of time. And just a little about my background. I've been working on the exercise physiology field for several years now. I'm actually a licensed exercise physiologist, and I have a bunch of experience with high blood pressure and populations with heart problems and heart diseases. I was talking about this with Jesus actually a while ago. So there's several articles and publications about the dangers of sitting down for 8 hours or so. It's comparable to the risk of obesity, high cholesterol, high blood pressure, and also it's compared also to smoking. So I think that's pretty crazy to think that sitting for more than 8 hours, it could be compared to smoking in some cases for some people. And I'm pretty sure that also, you know, having a sedentary life has some impact on the cognitive aspect also. So it will be interesting to, you know, explore more on the physiology of those complications, and also any studies or something around those lines for exercising and cognitive you know, decline, and also related to hypertension, obviously, like Jesus was saying. So I just wanted to add, you know, that little comment in there, and you know, thank you also, Jesus, for the presentation. It was really interesting to know, you know, what hypertension and the complications, you know, about it. So it was pretty interesting to me, and just wanted to add that little, you know, detail about what Dr. Meister said. But yeah, that's it.
No, thank you very much, Hector, and I appreciate that. And I think I'm going to look at that will be attributable risk associated with smoking or sitting. I have read some papers looking into the association and dying cardiovascular risk. I didn't know the kind of proportion between the two kind of risk factors, how much is attributable. And so I'm going to have a look at a book and those two, and probably, yeah, certainly we should later on try to test some hypotheses related to physical activity as well.
Yeah, that will be real interesting for sure.
Yeah, that sedentary is one of the 8 risk factors identified that we should have a look at as well. Yeah, thank you.